Okay, so good afternoon, everybody. And today we're going to talk about a very interesting case scenario, which is an unusual presentation of a common disease. So we often see many girls who come to us with abnormalities in terms of menstrual irregularity, in terms of period problems, in terms of hirsutism. And most of them, we either find they are either physiological variants, which are related to puberty, or sometimes they may have issues which are related mostly with regards to what we label as the garden variety PCOS. But a substantial proportion may have alternate pathologies, which may actually start off from PCOS, but may have significant implications. And that's what we're going to discuss today in more detail about these cases. So we will have a very interesting case which will be presented. And along with that, we'll have much more discussion about the underlying etiology, the pathophysiology of that particular condition, how that really takes place, and what are the problems which can happen if we do not manage these individuals appropriately at the right time. So I'll start off with one of the cases whom I had seen a decade ago in what seems to be a later manifestation of this case if she had not been managed properly in that regard. So this was a 17-year-old girl with hirsutism who was basically presented to some gynecologists immediately after menarche around 12 years of age. But now she had come to us with complaints of rapid progression. So she always had that feature of hyperandrogenism. There was oligomenorrhea. There were other features which were there, but now they were really concerned that there were more features which were suggesting of virilization, amenorrhea, muscularity, voice change, clitoromegaly. So of course, this would not be a sort of a malignant disorder. So we always say that if you have a very high testosterone level, if you have features of hyperandrogenism with virilization, start thinking of a possibility that this is a tumor, adrenal or a testicular ovarian tumor. But this, of course, was a very long duration history. So we cannot really label that as a cause. So there was something new which was happening here. And we found that the testosterone levels were in the virile range, in the male range. So this was classically a scenario wherein you had a background of hyperandrogenism, and then that hyperandrogenism led to a second problem. And this is something we always talk about, that hyperandrogenism begets hyperandrogenism. If you leave high androgen levels, the ovaries will be luteinized. You will have abnormalities in terms of LH surge. You will have more peripheral adiposity. You will decrease SHBG level. And this high androgen itself will be a self-perpetuating scenario. So it could be a vicious cycle. And that's why this girl actually landed up into a very complicated scenario in which she had a huge ovaries, in fact, bigger than her uterus. And it was hypertrichosis, a condition which is extremely difficult to manage. Now, when we saw this girl, whom we'll discuss now, we had some feature that this will progress probably towards that regards. But how did we manage, and how could we have improved the management to avoid this complication is the theme of this regard. So every girl who comes to you with abnormalities of hyperandrogenism is not just PCOS. You have to think of something beyond and look at beyond the ovaries in these girls as well. All of you can go and have a look at our website, learning.growsociety.in, which has got a lot of courses, validated tools, as well as learning modules, including fellowship and diploma programs. We do run frequent grand rounds, postgraduate lecture series, along with the PG grand rounds as well. We've got a mobile application which allows a point of care assessment of most complicated pediatric endocrine disorders to help in terms of protocolized managements, and our publications are available, including the pediatric endocrinology protocols, which has recently been published. So today what we'll do is that we'll start off with a case presentation, which Dr. Dhwani will talk about this case, and it will be an interactive one. So we'll try to see what was different in this case. And then from there, we'll try to take their thread about how do you diagnose this particular group of condition, what is the underlying cause here, how should we manage, and then finally we'll come back as to how did we manage this case and what was the final outcome, at least from that perspective. Before I go ahead, I'll just have a quick word about how hyperinsulinism. So all the theme is basically about hyperinsulinism and how hyperinsulinism really affects hyperandrogenism. So we know that if your insulin levels are high in the setting of insulin resistance, whether it's type 1 diabetes, type 2 diabetes, or there are insulin resistance syndromes, your insulin levels will increase and they will decrease the IGF-BP level, which will result in an increase in free IGF-1, which will cause a ovarian hyperstimulation. So ovarian growth will become more. The SHBG level, the sex hormone binding globulin levels will come down. So your testosterone levels will go up. Now, insulin also has a specific independent effect of IGF-1 on the ovaries, causing an increased thecal proliferation. It will have an effect on the adrenals to produce more adrenal androgens. It will have an effect on the LH suppression of the progesterone, causing a reset axis, as well as causing effects on the peripheral androgen production by acting on the 17 beta HSD. So hyperinsulinism of any cause will cause both ovarian, adrenal, and peripheral hyperandrogenism. So we are affecting the hypothalamus, the pituitary, the ovaries, the adrenals, and the adipocyte, and that's why it becomes very, very important. So the central theme today is how insulin resistance is pivotal and how that can cause a lot of problems. We'll start off with Dr. Dhwani, who will start off with this presentation on that.
Thank you, sir. So we know that the story of hyperandrogenism and insulin resistance is much like the chicken and egg story. It is often difficult to find out what came first and what caused the next. Similarly, we have this very interesting case where it will make you wonder whether it was a primary insulin resistance that predisposed her to develop hyperandrogenism, or if it was an hyperandrogenism which led to an insulin resistance. We have a 16-year-old girl who presented with primary amenorrhea, had development of secondary sexual characters by 12 years of age, and had developed hirsutism and acne for the last 2 to 3 years, which was more prominent by the time she was 16 years old and was milder at outset. She was born at term 2 kgs and had a smooth perinatal transition. On inquiring, there were no significant maternal risk factors for this IUGR growth. There was also a history of obesity and type 2 diabetes in father. There was no history of headache or galactorrhea, no history suggestive of virilization, like no deepening of voice, alopecia, increased muscularity here, no history of cyclic abdominal pain, and there was history of vaginal bleeding following a course of estrogen progesterone that she received previously.
So you have a girl who comes to you with primary amenorrhea at 16 years of age. In the background, that you also have some features of hyperandrogenism like hirsutism and acne, and the significant factor is that she was SCA.
Yes.
Could there be some other points, clues on history which can tell you that this is the likely cause, that the SGA is progressing towards that scenario?
Usually in such children, we get a history of precocious pubarchy and accelerated.
So precocious pubarchy would be something which is there. And how common is the primary amenorrhea, the presentation of PCOS?
PCOS usually presents as an oligomenorrhea or secondary amenorrhea. But yes, we must always consider in the setting of primary amenorrhea and hyperandrogenism, one must always think of.
So definitely, if you go by that angle, this means that it will be a more severe form. Because normally, if you talk about PCOS, it's a disease of the ovaries.
Yes.
So only when the ovaries are functional will you have those manifestations. So ovaries need to produce the hormones. And when they are producing that hormone, you have got both hyperandrogenism as well as hyperestrogenism. So you will have usually some periods. But what it means is that there may have been some other components going on, and there was disrupted steroidogenesis to begin with. So I think that is the important. So if you look at this case now, compared to what we are seeing in the other case I talked about,
yes,
this case basically had an onset around 12 years, but probably the ovaries were not functional to that extent. That girl actually had a much more severe course to begin with, and then she suddenly went off the loop from that perspective. So she did respond to OCP. That is one point which is there. So of course, anybody who has got intact uterus will respond to the OCP. But would you agree giving OCP in this scenario?
No, sir. It is important to evaluate for the cause of hyperandrogenism before we go on to the therapeutic measures.
Exactly. So I think first we need to see why is she having an amenorrhea. So carry on.
Yes. So this was the history that she presented to a gynecologist with, and initially her weight was 67.6, had a BMI in the obese range for Indian population, normotensive. The initial records mention a thylacine, pubarchy, and axillary hair appropriate for age. Initial investigation.
Now hold on. So if you now approach from a girl who comes to you with primary amenorrhea.
Yes.
If a girl comes to you with primary amenorrhea, the first thing you will say, okay, what's the breast development?
Yes.
Here the breast development is normal, stage 4, 5,
Yes.
I believe.
Yes.
Then next you will say, okay, what is the pubic hair development? Pubic hair is also normal. So that is also normal. Now, what will be the causes you will think of in a girl who presents to you with a normal breast, normal pubic hair and primary amenorrhea?
So the causes we need to consider in this age group, in this clinical setting are, one would be Mullerian agenesis. The other would be something like a vaginal septum where you have everything developed. And
Before that, so the first thing you will go into terms of that algorithm will be features of hyperandrogenism. So otherwise, because that's a totally different tangent altogether.
Yes.
So definitely you should look for whether there is hyperandrogenism, and that will give you a clue.
Yes.
Now, if you have a girl who presents to you with hyperandrogenism and primary amenorrhea, what are the likely possibilities you will think of?
Okay. So hyperandrogenism means that there is an increased androgen production. It could be of an ovarian source or an adrenal source. Usually those presenting with an adrenal hyperandrogenism tend to have a precocious pubarchy. They are leaner,
Yes.
like prepubertal.
So what you're saying is that hyperandrogenism is causing amenorrhea. Now this could be a CAH variants,
Yes.
adrenal tumors, or all those things presenting as primary amenorrhea. So that will be there. And of course, ovarian, as we were discussing. Can you have amenorrhea? Can amenorrhea cause hyperandrogenism?
Can amenorrhea cause hyperandrogenism?
Or anovulation, can
Yes.
anovulation
Yes.
cause hyperandrogenism? So when you have anovulation, you've got no progesterone. You've got no progesterone, you will have high LH and you will have hyperandrogenism. So milder hyperandrogenism can happen as part of the ovarian dysfunction. So you have to think of both possibilities.
Yes.
So in patients, let's say, who have got even premature ovarian insufficiency, before they're really going into a complete ovarian failure, they may also have hyperandrogenism.
Yes.
If you have hypothalamic amenorrhea, you may have both hyperandrogenism and that. So now if you look at it, you're talking about somebody who has got significant hyperandrogenism and somebody who has got amenorrhea. Now in this setting, if I want to really compare Dr. Vibha about adrenal versus ovarian part, how will you differentiate? What is more likely?
So in this scenario, generally,
In this scenario.
so the as she has severity of hyperandrogenism is more, so it would be more likely to be the adrenal.
So first thing I think if you have to look at would be, is there any precocious pubarchy? As you said, if it was there, that would be more significant. Leaner phenotype will go more in favor of adrenal versus ovarian pathology, although it can't be excluded. And of course, one thing which you would like to really look at in this case on examination would be acanthosis, yes, lymphadenation. But in terms of if you want adrenal prenatal versus postnatal virilization, how will you differentiate? Suppose somebody had CAH and it's a prenatal virilization. Now she has amenorrhea. So of course they can also present like that. So how will you differentiate between prenatal testosterone exposure versus postnatal exposure?
Prenatal testosterone exposure will continue to have high eligible.
You and also clinical. So which part you will examine? That will give you a. So if there is a labioscrotal fusion. So if there is a labioscrotal fusion, it will definitely mean that it's an antenatal. So of course that will be a more severe one. Can this be aromatase deficiency?
Yes, milder aromatase deficiency can present with the features of hyperandrogenism.
If you're looking at now, if you look at very simply, you have got high androgen, low estrogen. So of course, aromatase deficiency can also have a similar manifestation. If you have more severe form, you will have DSD to begin with.
Yes.
But you can have large cysts along with this manifestation, which can happen with aromatase deficiency.
But she has large.
Yes, so that is a very important part. So estrogen receptor defect and aromatase deficiency become out essentially because you've got a normal HeLa. So I think that becomes important. Carry on.
Okay. So on presentation to the gynecologist, her initial screening investigations were in the normal range, and TSH was slightly elevated. However, we do not have a T4 record here. And again, LH, FSH were documented to be high. And erroneously, this child was labeled as having hypothyroidism with hypergonadotrophic hypogonadism.
What was the FSH was? LH, because LH was 13.
Yes.
Okay. So Again, we discussed that you can have hypergonadotropic hypogonadism or POI, other cause of hyperandrogenism, but what will be the alleged FSH pattern? So if you look at it, there of course FSH will be predominantly high. Here you have got more LH high, which basically means more towards anovulatory / PCOS. If you had got a normal FSH and a low LH, what would you be thinking of?
Then this would go more in favor of a systemic disease or
so hypothalamic functional GNRH deficiency, and if both LH and FSH are low, that will be hypogonadotrophic.
Yes.
So always look at LH and FSH in context. Both high, very high FSH, high LH, hypergonadotropic hypogonadism, high LH or a slightly elevated FSH, think of a PCOS anovulation. A normal FSH and a low LH, think of a hypothalamic cause. Low LH, low FSH, think of a hypogonadism. So this is more like an anovulatory PCOS like picture. And TSH, I think, is because of obesity, so we won't be giving much value to that. Carry on.
So as a result of this, she underwent karyotype, which as expected was 46XX. And she was started on E+P combination at this point and was started on levothyroxine at 50 micrograms.
So would you now be starting estrogen in this case?
Not yet, sir. Again, we don't have an established cause yet. So
so they had not done any androgens or any other, we don't have any documentation, other things.
And even for PCOS, we need to rule out hypothyroidism, hyperprolactinemia, CH. So
sure.
On follow-up, her TSH levels were normal again. Prolactin was in the normal range, and LH-FSH continued to be high. And at this point, she was referred to an endocrinologist.
Now you say that prolactin was normal, but the normal range was less than 20. So what do you do in this 29?
So this is again, she was on E+P combination. So we do see slightly elevated prolactin. We may not really act that.
Generally, more than 40 is hugely significant. 20 to 30, I would be very cautious, do a repeat sample. So again, this is not the cause. Now, hyperprolactinemia, now this is another point. A lot of people say, okay, hyperprolactinemia is there, treat that, that is the primary cause. What is the usual manifestation of hyperprolactinemia in terms of this scenario?
Hyperprolactinemia will have oligoaminuria. Higher levels of prolactin will present with.
So it's mainly anovulation. Hyperandrogenism will be very mild. So if your predominant presentation is because of hyperandrogenism, frankly speaking, prolactin and thyroid are very, very unlikely. You're supposed to rule it out, but they become very, very unlikely. Cushing's and other things I will be more cautious about, especially. Carry on.
So even after she was, even when she was referred, she came to us after about 3 to 6 months of having been referred. When she first presented to us, she had already lost about 5 to 6 kgs of weight. She was now in the overweight range, and BP was pre-hypertensive maybe, but not really elevated. On examination, she had a buffalo hump and severe acanthosis with axillary freckling. And as you can see, even the flexor aspect of forearm, one could appreciate acanthosis here.
I think this is significant. So normally when you talk about any PCOS, we do see the acanthosis. But for a normal weight relatively or overweight individual, this level of acanthosis suggests that there is a disproportionate amount of hyperinsulinism here.
SMR showed a B5, P5, and she was menstruating on her E+P combination. Another thing that I'd like to point out here is usually what we see is an improvement, a significant improvement in symptoms when patients lose even about 10% body weight, which we did not see in this particular child. And the FGS score was 22, which is significant hyperandrogenism.
Severe level of hyperandrogenism, normal breast, normal pubic hair. So again, we're talking about a hyperandrogenic state basically. So in this scenario, would you be thinking of a virilizing disorder?
One would have to be cautious with such high FGS, yes.
So you have to obviously look for clitoromegaly, look for muscularity, look for other things, but the duration of history seems to be a bit longer. So if you talk about which is the most common virilizing cause you think in this age group?
An ovarian tumor.
Adrenal.
Okay.
So ovarian usually happens typically around 3rd to 4th decade of life. So usually it's an adrenal carcinoma and it's a much more aggressive pattern. But of course, you have to be cautious in that. Carry on.
So in our database, we have an overweight SGA female with well-developed secondary sexual characters, features of hyperandrogenism, insulin resistance, and presenting with primary amenorrhea. So what we have here is a hyperandrogenism responsible for primary amenorrhea, which is more likely to be of ovarian etiology than adrenal, and likely non-malignant cause because it has persisted for this 3 to 4 year period that we see. Our investigation showed a normal LH-FSH level.
So this would be because she is on treatment. So
Yes.
on treatment, of course, you expect these things to come down. And even the testo has come down.
Yes.
So if your testo has come down on estrogen progesterone, what does it mean? What is the origin? Ovarian. Because how does estrogen progesterone reduce testosterone?
Actually, estrogen progesterone increases the SHBG level. So the free testosterone level will
No, but total is good.
Sir, it inhibits the LH synthesis.
Basically, it is shutting down the hypothalamic pituitary axis. So if with E plus P or testo has come down, it means predominantly it's a non-autonomic autonomous ovarian production. What I'm trying to say that effectively, and okay, this is not an adrenal carcinoma, this is not a ovarian carcinoma as well, because you have got suppression with a E plus P.
Another thing that I want to highlight here is that this total testosterone was taken when she had an irregular course of E plus P combination that she was on, and she claimed to have stopped this medication about 7 to 10 days. But then again, as if you remember from the class, OC pills need to be stopped for 2 months before we test total testosterone. In the setting of having taken E plus P combination, free testo is a better measure. Even
but her actual testo would be lower than this.
Yes.
So which means basically, so you are actually, if you are taking E plus P, the total testo will be high, but the free testo should be on the lower side. So
yes.
in fact, if you look in the clinical scenario, it's even helpful. So it's like somebody who is basically having E plus P, still the testo is not very high, means it's very well controlled.
Her DHEAS was again in the normal range and 17 OHP levels were low, ruling out an adrenal cause of hyperandrogenism here. Prolactin level was a repeat prolactin level was normal here. 8 AM cortisol level which was done showed a high level. Thus, we went on to an overnight dexamethasone suppression test with which cortisol was suppressed.
Why is the 8 AM high?
Again, with obesity, we expect them to have.
You said that she was taking E plus P recently. So that will have an effect in 6 weeks. So ideally, you should do it after 6 to 8 weeks. But with ONDSP, if it has come down, we are okay with that.
And she had come to us with an ultrasound which showed bulky ovaries, right being 24 cc and left ovary 16 cc with multiple
so
small.
What's the normal ovarian volume?
Normal ovarian 25.
Anything about 10 in adults is considered to be high.
Yeah.
In adolescents, about 12. So it's a large, huge ovary. It's not a simple this thing. 24 cc is a double the size of the upper limit. So it's a big ovary that you are seeing. So this is something which suggesting something basically. Yeah, carry on.
And uterus was a slightly less volume as one would expect for this age, and there was 4.5 millimeter ET thickness here. So again, suggesting that this was a normally developed uterus. Moving on, in the setting of obesity, overweight, and severe acanthosis, we went ahead with complication screen and we found that the SGPT was elevated. Ultrasound abdomen showed a grade 1 fatty liver, suggesting that a non-alcoholic fatty liver disease had set in. Fasting and postprandial blood sugars were very high, suggesting that a dysglycemia had also set in this child.
So how commonly do you see type 2 diabetes in the setting of PCOS? So somebody who comes to with routine PCOS, how many of them are type 2 diabetic? Very rare. Okay. It will be like 2-3% or even less than that. So this again is giving you a clue that here hyperinsulinism seems to be the predominant manifestation. It's also affecting the ovary. That's what it's looking at. And if you look at, there is also a steatohepatitis which is there. There is not much in the lipid profile, but predominantly we are looking at in terms of the diabetes, which is quite unusual for she is 16-year-old.
Yeah.
16-year-old diabetes again, it's a significant thing.
So now we have an overweight SGA female with hyperandrogenism and primary amenorrhea with features of insulin resistance and metabolic syndrome, who had normal screening, normal testosterone DHEAs, although on treatment. So the possibilities that we would consider here, a PCOS would be a very strong possibility in the setting of an SGA female. Paternal history of obesity and type 2 diabetes, again, is an important risk factor. Ovarian hypothecosis should be considered here because hyperandrogenism has been going on for a long time. And with such significant HGS of 22, one should always be wary of, and such bulky ovaries on ultrasound. Another possibility that I would like to consider is a primary insulin resistance in form of Hayran syndrome, predisposing to hyperandrogenism and
so I think all of this, if you look at what really is PCOS, how do you define PCOS?
PCOS is a sustained ovarian hyperandrogenism.
So unexplained,
Unexplained,
sustained, prolonged hyperandrogenism of ovarian origin.
Yes.
Now, these three terms, although we are talking them as a separate terms, are pretty similar or a part of spectrum. Now, predominantly, you've got insulin resistance, which is a fundamental. So, PCOS, you've got ovaries which are destined to be abnormal. When the environment, your insulin resistance is more, they develop PCOS. Then the second, of course, is ovarian hypertrichosis, is the most severe form of PCOS. Once the hyperandrogenism has been neglected, as in the first case we discussed, you've got this whole cycle going on. And when you say primary insulin resistance, of course, you're not talking about these severe congenital forms. You're talking about more acquired autoimmune forms or other things, which will behave like PCOS. So I think all three of them are pretty similar in terms of that. Now, whether you put in one basket or the other will be a different thing, but ultimately they will be quite similar in that regard.
Another theoretical possibility that I had initially considered was a sulfotransferase defect, because we also had a normal DHEAS level. But then again, on reviewing literature, I found that these usually...
I think what you need to give a very, very important thing is that you've got diabetes as a primary thing. So if you put everything else and you see there is a definite diabetes which is there. So that's something you have to be very, very cautious about in that perspective. So this predominant problem here is in terms of an insulin problem. And then you have, because otherwise, so whenever you are explaining, you have to put that diabetes, you have to explain, and severe acanthosis. So I think this is a very good this thing. We'll see if there are any particular questions till this point of time. And this was a very interesting case, and we thought we wanted to highlight some particular scenarios which can basically focus on this aspect as well. So I think now we will carry forward into this regard, as I've said, that these three conditions, if we say whether it's a primary PCOS, whether we say it's an insulin resistance, or we say a Hayran, they're all part of the spectrum. And what I say is that if we had not treated at the right time, now we talked about why E+P should not have been given, but if it had not been given appropriately at this point of time, she could have progressed rapidly from that regards. So now we will have a few words about the overall scenarios to what we are talking about and what we are thinking as a primary possibility. We have got one question, Elsie. So how to approach a prepubertal girl with acanthosis and insulin? We'll discuss this towards the end then, Dr. Ankita. And so we have got Dr. Alapan, who will be talking about what exactly is this Hayran syndrome and how is it different from a conventional PCOS?
Thank you so much, sir. I'll start from exactly where Sir Dhani ma'am has ended this discussion, whether the chicken started first or the egg. So there is this cycle of this hyperandrogenism and the insulin resistance, and it goes hand in hand. Actually, whether the insulin resistance comes first or the hyperandrogenism, I'll answer this in my subsequent slides. So as we all know, this Hayran is nothing but a triad of a insulin resistance, which is the main culprit, I think, about this. And there are also the sequelae of hyperandrogenism and acanthosis that is present. Now, how common it is in our day-to-day life practice, and as per the literature review, in the late 90s, there are such research articles and case reports which shows that it is merely 1 to 3% of all women present with hyperandrogenism. And in the subsequent case studies, recently in 2004, there has been a cohort study that has been done with 1,000 of hyperandrogenistic women, and it had shown that almost 5% of all women presented like a hair and like syndrome. And also an interesting data about this, that they had given a demographic and clinical profile of that patient, and majority of the patients were in the obesogenic environment. So what is this insulin resistance? Insulin resistance is something that in a cell or in a whole body, the insulin is disproportionately high to elicit a normal quantitative normal response. And this insulin resistance is basically classified into two categories. The one is intrinsic or the primary insulin resistance, another is the secondary one. The primary resistance is usually due to the receptor defect, and this receptor defect could be the presentation like synthesis of the receptor, or it could be due to the post-translational defect. And there are also secondary insulin resistance like state, like in physiological state, like in obesity, like in puberty, also like in the pathophysiological states, like in the obesity, some endocrinal causes like growth hormone excess, or some autoantibodies to the insulin receptor. Some have classified this insulin resistance also into three categories, like type A, type B, and type C. Now, if we see the case reports regarding the insulin resistance, there are one case report that has been published in India in 2020, and it has shown that the BMI range, the BMI is in the obesity range, and also the similar profile has been seen in 2004. There has been a case report using a cohort of hyperandrogenic women in Lexington, where similar weight and BMI has been described. Now, among this type A, B, and C, some case reports have dealt with that this is a kind of type C type of insulin resistance, where there is usually the presence of obesity causing this insulin resistance. Now, how this insulin resistance is caused by this obesity? As we all know that obesity causes increase in the free fatty acid level, as well as inflammatory cytokines and leptin levels. Also, they decreases the adipokines and adiponectins level, which contributes to the insulin resistance. But this insulin resistance is a selective resistance. That means it only acts on the level of the liver and the muscle, but the skin and the ovaries are responsive to this insulin. The primary abnormality, as we have already discussed, whether the hyperandrogenism causing this insulin resistance or this insulin resistance is causing this hyperandrogenism, we have this case reports where it has mentioned clearly that the insulin resistance is the primary culprit which is causing this vicious cycle of hyperandrogenism, which further potentiates the insulin resistance. At the same time, we have this question, as Saraj already described, whether this PCOS and hair end are the disease of a similar spectrum, whether this is hair end is a subtype of PCOS. And our textbook of Sparling has clearly mentioned that it could be a case of subtype of a PCOS, where the severe kind of PCOS could be labeled as hair end syndrome. And usually it is seen in association with the obesity.
So what are the genetic testing? Has genetic testing being done in these individuals and they are found to have specific receptor defects or variants?
Yes, sir. Insulin receptor? Yeah. So they have done insulin receptor defect like in the insulin type A receptor defect, whether there is a defect in the synthesis or post receptor PC1 defect they had shown. They had also shown IRS1 kind of defect, where it could see as a insulin resistant like state. In another variety, they had shown there is autoantibodies present, and it is usually present in the middle-aged woman. But yes, sir.
Genetic and that. So in terms of classical hair end, how many of them, let's say 5% have of hyperandrogenism have hair end, how many of them will have a genetic defect? So that becomes a big number. So if you say we are seeing so many patients with PCOS, 5% are hair end.
Yes, sir.
Within them, how many would have genetic defects? You don't have any idea on it.
No, sir, there is no data.
So, yeah, carrying.
Now, in this study, we can see there are two groups, group A and group B, where they have taken 30% each in each group. The group A is consist of hair syndrome and group B is PCOS. But here you can see a significant overlap that is present in hair and PCOS, and they are clearly mentioned that insulin resistance is one of the several pathophysiologic mechanisms in PCOS, where we know there is a two-hit model. Initially, there is a fetal hyperandrogenism or fetal undernutrition like state, followed by in a puberty or a insulin resistant like state, it is grown into a full-blown picture. But in case of hair, it is only the insulin resistance that comes first, which further causes this kind of similar problems like acanthosis nigricans, like in the insulin resistant and diabetes, which is much more associated with this kind of symptoms.
How did they differentiate between this is hair and this is PCOS? What were the major clinical criteria that were distinguished?
Sir, regarding the clinical criteria, we have in diagnosis of hair, we have three things: hyperandrogenism, we have insulin resistance, and acanthosis nigricans. But in case of PCOS, there is anovulation or anovulation. The PCO morphology could be present.
No, but anybody with hyperandrogenism will have anovulation. Anybody with hyperandrogenism will have PCO morphology. So how did they? I'm talking about this study. What criteria they choose that okay, this I think 12 are overlap. But what were those 18 who were pure hair?
They don't have, sir, any anovulation or like that similar like of menses were not so much irregular, sir. Actually, they had some.
Okay, because you need to be very, very precise, because if it is the same spectrum, then classifying them becomes more of an academic consequence rather.
Basically, they had also done some LH level and FSH level, and they had shown that LH level is much more higher in case of PCOS like condition, where it is normal to lower in case of hair syndrome. Also, acanthosis nigricans is much more common and prevalent in case of hair syndrome rather than PCOS.
So what you're trying to say is that both of them have insulin resistance. One has got more ovarian manifestation and one has got more cutaneous manifestation. Yeah.
Now the acanthosis nigricans, the skin manifestation of hair acanthosis nigricans is nothing but a symmetric velvety hyperpigmented patches on the skin, and is usually seen in case of axilla, in the antecubital fossa, in the groin, or in the inframammary region. And the main culprit behind this acanthosis nigricans is the IGF-1. As we all know, due to this insulin resistance, there is hyperinsulinemia. This hyperinsulinemia actually increases the IGF-1 receptor in the keratinocytes of the skin, as well as it decreases the IGF-BP level and increases the free IGF-1 level that acts on that IGF receptor, causing this acanthosis nigricans like picture. If we get a pathological slide, we can see that hyperkeratosis and papillomatosis in the pathogenesis of acanthosis nigricans.
So I think, so basically what you're trying to say is that these two are similar disorders, and the major difference that you are seeing is at the level of whether you have got cutaneous manifestation or a ovarian manifestation on that. But as they themselves said that 12 of them, they were unable to make a diagnosis. So there is no clear cut say that this is definitely hair and this is clearly that. So essentially every PCOS will have some acanthosis, which you will see pretty much there. And everybody who has got insulin resistance will have some amount of ovarian this thing. So I think the major difference is how much is their ovarian sensitivity and how much is their insulin resistance peripherally, which will decide about that. But the big message probably which is coming from all this is that if you have uncontrolled hyperandrogenism for a long time, you will have dire consequences. And that's why it becomes important to act at the right time. So we'll take a couple of questions at this point, and then we'll continue about how do we manage this scenario, and we'll go forward on that. So we have got a few questions. What about isolated insulin resistance with alopecia? So this is again a sort of a scenario in which you will have manifestations. So again, cutaneous sensitivity to androgen will also vary. Some people will have predominant acne as a presentation, somebody will have alopecia as a presentation, somebody would have hidradenitis suppurativa as a presentation. So you need to have an eye open about a wide variety of presentation. Dr. Ankita is asking how to approach a prepubertal girl, 8.2 years, with acanthosis with insulin level 21. So essentially, this largely it will be more of a lifestyle interventions. We should get their blood sugars and SGPT levels done. If they are normal, mainly lifestyle intervention is there. We need to be cautious about weight gain, and that should improve. What about type B insulin receptor defect? So there are, as discussed, various forms of insulin resistance. So of course, the most severe ones are the insulin receptor problem right from birth, the Rapson-Mendenhall syndrome. Then we have got ones in which there are genetic variants, and then there is a autoimmune variety. So in which this autoimmune antibodies will block the insulin receptor to act. These I would say, that's what I wanted to know, is probably much less common as a cause of a garden variety. So everybody with PCOS, you don't need to consider that. But yes, some rarer cases, you will have those manifestations which will happen. What is very unusual in this case, however, was that she had actually developed diabetes, frank diabetes by 16 years of age. She had steatohepatitis. So PCOS was a part of the manifestation, but predominantly insulin resistance was the major factor from that regard. So we will carry forward further about the management aspects as to what we can do. So just to touch base about what are the various options available, of course, the major problem is hyperandrogenism. So we want to correct the hyperandrogenism, the high testosterone level, and its adverse effects. So primary treatment in most scenario is estrogen plus progesterone, which is basically going to cause suppression of the LH, as we discussed, which is going to decrease the ovarian androgen production. You will also increase SHBG, so the free testosterone levels will come down. The second big culprit, of course, is this insulin resistance. So you want to reduce the fat using lifestyle intervention, using metformin, which will cause sensitization in this perspective. And then follow up, you can use really GnRH analog, which we had to use in the first case because of very severe hyperandrogenism, and which is going to cause a lot of problems. If you don't knock out the ovaries, they will cause more hyperandrogenism. You can use progesterone only in scenarios where the problem is predominantly a menstrual irregularity, which will suppress LH. Now, if your androgens have come down or you're not able to bring them down, you can think of agents which can affect the action. So you can use finasteride, which will affect on the 5-alpha reductase, or spironolactone, which will act as an anti-androgen. And of course, finally, local measures can be used. And if there is a functional hyperandrogenism, which is adrenal origin, you can think of hydrocortisone. So this is the various modalities we can think of. And now I'll invite Dr. Vibha, who will be focusing about these more strategies in detail as to how do we go forward, particularly with regards to the hyperandrogenism as a scenario.
Thank you, sir. So before coming to the management, I'll be discussing the whole management of the hyperandrogenism. And let's begin with the case. We have this 15-year-old adolescent girl who visited us for the menstrual irregularity. She had menarche at the age of 12 years old. And she was obese, as her BMI was very high, that is 33, and she had acanthosis as well. And on the examination, we found that she has a severe hirsutism. That is, FG score was 28, but there was no sign of any virilization. She had a positive family history for diabetes. On the endocrine workup, we found her testosterone level was very high, and both LH and FSH was in the normal range. The blood sugar was also normal, but the insulin levels were very high. Now the question comes here, this is surely an obese girl with acanthosis, hyperandrogenism, and with a high level of testosterone, so looking like a case of hyperandrogenism to me. So the question comes, how should I manage this patient? So as we have discussed a lot, like insulin resistance is the supervillain in this story. So we need to decrease the insulin resistance first, and it could be achieved by the lifestyle modification, which is the primary first-line therapy in the case of hyperandrogenism. And it could be done by the weight reduction of over 10% of the weight reduction from the baseline of weight, which should be achieved over a period of 6 months. And a weekly or the monthly goal could be set to reduce the weight of around 1 kg to 1.5 kg per month. The patient should avoid crash diet, and the balanced diet should be taken with a high fiber and the protein of 1 gram per kg and reduce the calorie deficit by 30% and ask the patient to increase the physical activity to at least 60 minutes per day, which include both aerobic and the muscle strengthening exercises. Now, there is a very old paper which showed the effect of weight loss on the hormonal profile. And in this paper, a group of 58 obese women with menstrual irregularities were included, and out of which 35 took part in the weight reducing program, which lasted around 32 weeks, and they had lost around 10.2 kg weight. And with the weight loss only, they showed a significant reduction in the glucose and the insulin and the DHT levels. So the next question comes, if the this weight loss is causing decrease in the serum levels of insulin, DHT, and the testosterone, so is it sufficient? Now coming to the second point, as sir has discussed, the hyperandrogenism is the main another factor to be considered. And for this hyperandrogenism, we should add the E plus P preparations. And how do they work? They suppress the hypothalamic pituitary ovarian axis that lowers the ovarian androgen production. It increases the SHBG levels, which decreases the free testosterone, and it further reduces the hyperandrogenism. It improves the menstrual cycle irregularity, but the studies have shown that the E plus P preparations have no improvement in the insulin resistance. So, and among the E plus P preparations, the combinations are better, which contains drospirenone or the cyproterone acetate, because these are the spironolactone analog and they work as an anti-androgen, and that will reduce the hyperandrogenism. Now, there is a paper showing the effectiveness of drospirenone on the treatment of hirsutic women on the polycystic ovary syndrome. In this study, they have taken 15 hirsutic PCOS patients, and they gave it to 30 microgram of ethinyl estradiol along with drospirenone for 12 cycles. And what they have noticed that the increased body hair growth significantly reduced after 6 cycles, and the plasma LH levels, the DHEAs, the 17-OHP also reduced to a significant levels, and there was an increase in the SHBG levels. They have also noticed the reduction in the FGS score as well. Now, the same patient visited to us after 15 days, as she had stopped all the medications because these medicines were causing nausea, headache, and dizziness. Her BP was also on the higher side. Now, the next question comes, what should we do in these scenarios? The one option is we can reduce the dose of the ethinyl estradiol, and we can stop it for a bit and restart with a lower dose. And the other option that we have in these scenarios is the GnRH agonist. It will suppress the ovarian function, and this is basically indicated in the patient, those who do not tolerate E plus P preparations, and in the cases of severe hyperandrogenism with suboptimal response to E plus P, like in the cases of ovarian hypertrichosis. The guideline is recommended to use the low dose of estradiol preparation along with cyclin progestin with the GnRH agonist for the facilitation of the vaginal lubrication and the bone health as well. Now, the same girls visited to us on the follow-up after 4 months. And again, she was complaining her cycles are still irregular. She hardly lost any weight, like she lost only 2 kg of weight. The acne, hirsutism, both were present as like previously, and the testosterone level was high. She has now become pre-diabetes at this visit. Now the question comes, why she is not responding to the treatment that I have given. I have given E plus P for the hyperandrogenism. I even advise her to, she has followed the diet plan, she has done exercise, but still she is not able to lose the weight, and her hyperandrogenism has not responded to E plus P. What do I miss in the treatment? As previously described by my, as previously explained by sir, There is a need of insulin sensitization in this patient because the insulin resistance is the main factor. So, and metformin is the best way to overcome the insulin resistance because it decreases the hepatic glucose production, enhances the peripheral glucose uptake, it increases the insulin sensitivity, which improves the ovarian function, and it also reduces the weight loss. It has an additional benefit that it decreases the atherogenic effects of E plus P preparations. And the guidelines recommended the dose for the lean adolescent girl is 850 milligram daily, and it should be started with low dose of 500 milligram. As she tolerate 500 milligram daily, then we can increase the dose. And for obese, we can go up to 1000 to 2000 milligram per day in the 2 divided doses. The patient should be advised to take the OD doses during night time to minimize the side effects of nausea. There is a very good study showing the effects of metformin on the polycystic ovarian syndrome patients, and it was a randomized double-blind trial. It was basically a 2-step study. In the first RCT, which was double-blinded, placebo and metformin was given to the patients, and then in the open trial, the metformin was continued in the same patients who were previously taking metformin. And what they have seen, after the intake of metformin, the BMI, the free testosterone levels, DHEA levels, both all the parameters have reduced to a significant level, and even the fasting blood glucose, insulin levels, and triglyceride LDL were also reduced. Now coming to what is the need for androgens? Should I add anti-androgens in this patient? Definitely we need to add anti-androgens in this patient, as she still have acne and hirsutism, which has not responded to the E plus P preparations. So what are the options we have here? We can give spironolactone, which is the most commonly used anti-androgen for the treatment of hyperandrogenism. And we should start with a lower dose, 50 milligram per day. It should be divided in 2, and we can titrate it 200 to 200 milligram per day. And the action, as we all know, it competes with the DHT for binding to androgen receptor. It moderately blocks the 5-alpha reductase locally, and it also blocks the conversion of testosterone to DHT in the dermal papilla cells. The major side effect that we have with this spironolactone is the hyperkalemia. So we need to monitor the blood potassiums regularly, and the spironolactone cannot be given to the childbearing age group women because it has a teratogenic effect. The male fetus could be under-virilized by the side effect of spironolactone. Now, another agent that we can use here is the cyproterone acetate. The recommended dose is 50 milligram per day, and it is given the first 10 days of the menstrual cycle. The liver function should be monitored, and it comes with the name of Diane, which contains 35 microgram of ethinyl estradiol and 5 milligram of cyproterone acetate. The another agent that we can use is the finasteride. It is used when there is no improvement with the maximum dose of spironolactone after 3 months, and the recommended dose is 5 milligram OD. Now, we should also advise the local therapy because the patients are very nervous and very concerned about the acne and the increased facial growth. The local therapy that we can advise for the acne are the topical antibiotics, which include clindamycin, minocycline, azithromycin, topical retinoids, 1% adapalene gel comes in the gel form of the cream. There is a topical anti-androgen also, which comes by the name of clascosterone 1%. And when the acne did not respond to the above topical treatments, we can consider topical 1% dapsone gel also. For the hirsutism treatment, aflornithine hydrochloride is very beneficial, and it comes with the name of Aflora cream, which can be applied locally at night. Waxing, photoepilation, and the electrolysis are the other methods for the local removal of the facial hair growth. Now, on the follow-up, the same patient come, but she was complaining she had no weight loss. She has taken all the medicine, But now her blood sugar has gone up. She is diabetic now. Now, what should we do? What are the options that we have in this scenario? We can use orlistat because her BMI was 33, very high, and we need to get rid of the weight anyhow. So we can start orlistat here. It is a lipase inhibitor. It decreases the weight, lowers the blood pressure also. And another option, as she's obese along with a blood sugar in the diabetic range, we can also consider liraglutide, which is and exenatide injections, as they are GLP-1 analog. They decreases the gastric emptying, causes the glucose dependent insulin release that further decreases the insulin levels, and they also improve the glycemic controls. Studies have shown that the patients with PCOS have lower levels of incretin. So by adding liraglutide or any GLP-1 analog would be beneficial in this scenario. There is another agent, that is myoinositol. Basically, this is a second messenger, which is involved in the insulin signaling. And by adding it, we can reduce the BMI also, and it improves ovulation. Here is a very good study showing the effect of liraglutide on the metabolic profile on the women with Heron syndrome. And in this study, they have given liraglutide along with the combination of metformin, and they have shown significant improvement in the degree of insulin resistance, fat deposit, and androgen levels. As you can see in the table as well, the BMI has reduced to significant levels. The triglyceride, glucose level, testosterone level, androstenedione levels, all have reduced after the introduction of liraglutide in the patient. So now coming to the scenario, the patient lost to follow for about 3 years, and then she revisited again. She gained weight again. She had irregular menses. The Ferriman-Galvis score was the same, but still she had no signs of any virilization. According to her, she was taking all her medication, but she was not taking any GLP-1 analog due to the cost issues. But her SGPT levels have gone up this time. The lipid profile shows dyslipidemia, and she has a high BP. Now, what has gone wrong? What could be the reason of this metabolic derangement in this patient? So it has been well known and well discussed in the studies that the girls, those who have PCOS, have twofold higher risk of having a metabolic syndrome. And the American Association of Clinical Endocrinologists has given the criteria for insulin resistance syndrome in the PCOS patient, and that includes if there is a reduction in the serum HDL cholesterol to less than 50, and increase in the triglyceride levels to greater than 150. Hypertension is defined by the blood pressure of greater than 130/80, and the fasting glucose and the postprandial glucose in the diabetic range. And they have also recommended that there should be a regular screening for the diabetes by the age of 30 years in all patients of PCOS, including both obese and the non-obese women. So now coming to how should we manage the dyslipidemia in the patients of PCOS? We can advise the lifestyle modification. We can prescribe them the low-fat diet, low glycemic index diet, omega-3 fatty acids, alpha-lipoic acids, and increase the physical activities. According to the American Health Association, we should treat the dyslipidemia on the basis of this risk stratification criteria. And if the calculated HDL is greater than 160, even after the 6 month of lifestyle modification, we should definitely treat the patient. And for the moderate risk, if the HDL is greater than 160 after 3 months of lifestyle change, we should treat it. And in the high risk patients, when the HDL is greater than 130, we should start the statins and the lifestyle modifications immediately in the patients. Now coming to this glycemia, as we have in these patients, we can start the OHs like the DPP-4 inhibitor, which have increase in creatine effect, and we can consider other OHs as well. Now, for the resistant cases of PCOS, for very severe obese patient, when the BMI is greater than 35 gram per kg meter, we can consider bariatric surgery, which is bile pancreatic diversion. For the severe hyperandrogenism, those who do not respond to any treatment, laparoscopic ovarian drilling can be considered. And the PCOS patients who presented with infertility and who showed no response to the clomiphene citrate and the letrozole, GnRH agonists can be considered. There is a novel therapeutic option that has been recently started, and that is a GnRH pulse generator, which decreases the frequency of GnRH pulses, and it acts on the neurokinin B receptor. It is an agonist, and it decreases the frequency of the GnRH pulses. So in this way, we can manage the patient, and our patient is completely, and I'll hand it over to Dr. Dhwani for the further discussing the management of this patient.
I think the main issue is that we need to have a multi-level treatment in individuals who present to us with PCOS. And we need to hit early and hit hard. That is a big message, because this girl already had diabetes. If she had not taken good control, she will have many more metabolic complications. Blood, of course, there would be issues in terms of her ovarian dysfunction. So, Dhwani, you can continue with what we did in this case.
Thank you so much, sir. So, as we know that she had complaints of amenorrhea, she was started on E+P preparation, but even on E+P, she had an undulating course with no withdrawal bleeding, having received multiple courses of progesterone to cause withdrawal bleeding, and then started on E+P again. But when she came to us, she was diagnosed with the type 2 diabetes and started on metformin, which worked wonders for her. So once we addressed E+P and added metformin, addressing the issue of insulin resistance, her cycles became more regular and compliance improved because of that. For a subclinical hypothyroidism, a repeat TFT was done, which was in the normal range, and levothyroxine was stopped here. For hyperandrogenism, again, as I've already mentioned, and as Vibha ma'am has very well mentioned on the target that you'll see. So targeting the ovary, we were already giving her E+P. For targeting the insulin resistance, there were again two things that we were targeting. So we started her on metformin, and lifestyle modification was advised. For hyperandrogenism, local measures were advised, and the family was counseled that it will take time for hirsutism to go down, and they need to be patient for 6 to 9 months to prevent further growth. Having looked at amenorrhea and hyperandrogenism, for her type 2 diabetes, she was upfront started on vildagliptin and metformin combination, with which she continued to have, she persisted to have sugars on the higher side. Therefore, dapagliflozin was added transiently. However, because of multiple drug therapy and poor drug compliance, we gave her a trial of metformin 1000 with vildagliptin 50 twice daily. Even at this, her last report showed an HbA1c of 5.8, and dapagliflozin was added again. For her steatohepatitis, lifestyle management was followed, with which her SGPT levels improved. And lastly, for dyslipidemia, again, she is currently on lifestyle measures. She was initially started on rosuvastatin, but again, we need to be wary that in females of fertile age group, rosuvastatin should be avoided, and especially rosuvastatin should be added only once you've proven that with lifestyle measures the lipid profile did not improve. So in follow-up, currently she has regular menstrual cycles. There has been no progression of hyperandrogenism. Last free testosterone level was in the normal range. She's recently gained weight, which could also explain why her glycemic profile worsened recently. And we know that DAPA was added in the last visit. Her HbA1c is 5.8 and SGPT is 30. Last lipid profile also was in the deranged range, where her non-HDL was more than 130. And that could be something that we could, with stricter weight reduction method and lifestyle, we could probably follow it up and see if she really requires medication at this point of time or not. So the take-home message from this case, that hyperandrogenism should be considered as an important etiology in the setting of primary amenorrhea. Aggressive management as early stage is needed, as sir has also tried to point out multiple times, that was E+B warranted at an early stage or not. So yes, we need to rule out, we need to evaluate for the cause of hyperandrogenism here, and then only start OC pills or E+B combination. But it should not be delayed, because the more we delay it, the more hyperandrogenism will progress and will lead to ovarian hypertrichosis. And timely workup and management of complications is essential here to improve the long-term quality of life.
Thank you, Vibha.
Thank
Thank
you.
you, Dhwani, as well. So this was a very interesting scenario. So again, the key message is that often we tend to say, okay, this is early stage, whether we want to start treatment or not, whether we can wait and we can label them as at-risk PCOS. The message is she had a significant hirsutism. She had a FGS of 22. In that scenario, there's no point waiting. So even if it is at-risk PCOS, you start treatment and you tell the parent that, okay, maybe sometimes later, 2 years later, if she loses weight, we can consider stopping treatment earlier, but then we have to start treatment, because as we saw in the first case, you can have significant implications of this level of androgen levels being there at a high state. So I think the key message from this presentation is that what we should not be lost in terms that this is actually a type A, type B, insulin resistance, this is Heron syndrome, this is PCOS. All of them are a similar manifestation. The crux here is that insulin resistance is a fundamental pathophysiological problem in all of these scenarios. Some people have got more ovarian sensitivity to insulin, which will cause more PCOS-like manifestation. Some will have more cutaneous resistance, which will present more like acanthosis. But ultimately, you have to focus on three things. You have to focus on lifestyle, focus on insulin sensitivity, as well as ovarian. In a way, you can say calling or giving ovaries a rest. That sort of a scenario that will be helpful in terms of stopping this vicious cycle of hyperandrogenism. If we do not, we will land up in the first case that we talked about, neglected for 5-6 years, and suddenly they will come. This is like a furnace. So it's like you are preparing the ovaries for a bad shape, and suddenly they start producing a very, very harmful amounts of androgens causing virilization. So I think this was the key message why we chose this case. If there are any further questions, we will take them there. Otherwise, I'll definitely invite all of you to have a look at our website and our channels, in which we have got a lot of presentations on these scenarios, including hyperandrogenism, and we'll close this session now.